Thank you.
Thank you, Paul. I really appreciate the opportunity to be here and to speak to everybody tonight. I'll start just sort of briefly and then give you a little bit of background about myself, and then walk through a presentation that sort of covers the role and the impact of medications for addiction treatment. And then, as Paul indicated, save some time at the end so that we can have a discussion. And I think that's really where a lot of the traction and learning comes about. As Paul indicated, I've been here since '91. I'm trained in general internal medicine and primary care, and subsequently did some training in research methods. And I was lucky in that I landed in a spot at Yale where I was working with a group of psychiatrists who, 40 years ago said, there's just not enough psychiatrists, there's just not enough specialists. We need to think about what tools we have that work and how we can move them to where patients are and where patients feel comfortable. And so as a primary care physician, I had the ability to take advantage of a lot of that. And I'll walk you through some of the work that we did. So, and as Paul indicated, I now direct the program in addiction medicine here at Yale, and we really work on 4 prongs: clinical practice, research, education, and policy. And so we really try to make sure that we have faculty and collaborators that are able to address the issue of addiction from all of those perspectives. And we're not just faculty in the medical school, we're also faculties in the School of Public Health, the School of Nursing, and the law school, quite frankly, because there are a lot of legal and regulatory issues that come up that we need to address. So with that sort of brief introduction and overview, I'll go to my slides, and just bear with me for a second so that I can set these up. Can you see this? So the outline and the content that I'll walk us through probably take about 20-25 minutes, and then leave time for discussion, is sort of talking about the neurobiology of opioid use disorder, the various treatments for opioid use disorder, and I know that many of you are very familiar with this. Compare some of the outcomes that we see with those various treatments. Address a common comment that I hear from folks is, aren't we just replacing one drug with another? Try to delve into the issues of how long patients should take medications for addiction. What's the role of behavioral counseling in addition to medications? And then probably spend less time talking about the biology of alcohol use disorder, the medications that are available for alcohol use disorder, and then one of the other big killers is obviously tobacco, and talk about the role of medications for treatment of tobacco use disorder. So I always start with this slide. I used to have a slide before it that asks the question, why do humans prefer opium over broccoli? And it just, highlights and reminds me to talk about the fact that many of the behaviors that we see that are associated with addiction, boil down to these central neural pathways that are highly conserved across eons of time and in various species. If you're familiar with this, you realize that we always talk about the VTA, which is right in the middle of this picture, and which is the ventral tegmental area, and the NA, the nucleus accumbens. These are very deep-seated portions of the brain, and they're transmitters that pass between those areas that really sort of create the euphoria, the reward that we experience with many things in life, including seeing beautiful pictures and feeling satisfied after a meal, reading beautiful poetry. And those are really the pathways that get hijacked in addiction. This is a little bit different view. So now we're looking inside of a cell, sort of from the side. And you can see up top, there's a morphine molecule that's binding to this balloon, which is the cell and the receptor. And then there's all kinds of activity that takes place within the cell. And that's really the cascade of events that when we have substances in our bodies takes place. And one of the really key events that takes place in this slide is down at the bottom right, where it says altered gene expression. And what that means is over time, with repeated exposure to these substances, the cell starts making different proteins. And so there are changes. There are changes in the content and the way that the cell responds in various situations. And those changes are really sort of the characteristic features that we see in addiction over time. And it's really as a result of that change, what we call gene expression and the proteins that are made that results in the biology that we see. So in less pictorial format and sort of in word format, we know that opioids bind to very specific receptors in the brain. These are the mu opioid receptors. Those receptors are part of the natural reward system of the brain. I talk about endorphins and Fiellins, the things that people talk about when they talk about a runner's high. And those repeated bindings of the opioids leads to those cellular and receptor adaptations so that they function in a different way than they did before they had this exposure. And what we see clinically, and what we see in our families and our loved ones and our patients, is they develop what's called physical tolerance. So because of that repeated exposure, they now need more of the substance to get the same effect. And similarly, if we were to stop the substance completely, they would experience a withdrawal. So those are sort of the physical and psychological manifestations that result from these changes in biology. We also see craving, repeated use. And so I take the time to talk about this at the beginning because this neurobiology helps to explain sort of the unexplainable. Why do people go back to using these substances once, for instance, they've gone through a detoxification, or we've taken them, put them in the hospital and separated them from access? And it's really these neurobiologic changes that persist over time that explain the chronic and relapsing nature. The other thing about them is that they really sort of form the target for the treatments that we use. This slide is designed to sort of schematically highlight three of the major types of medications that we use for opioid use disorder. The y-axis is the effect of the opioid in the brain. The x-axis is actually the dose of the opioid. So to the right, you're getting more. And there are basically three types of medications that we have. The flat line at the bottom is naltrexone. So that's what we call an antagonist. It binds very tightly to the opioid receptor, but it doesn't activate and it doesn't cause any opioid effects. And so it sits there on the receptor. It's akin to naloxone or Narcan that we use for an overdose. So it binds very tightly and it gets all the opioids out of the way. The next lineup is buprenorphine, which is what we call a partial agonist. And you can see that it has a characteristic at low doses. It has some effects, but it sort of has this plateau or this ceiling. And then the third medication is methadone, similar to other full opioids such as heroin, morphine, fentanyl. in that the more you give, the more activity you get at the receptor. And that's the reason why somebody, if they were to take too much of this medication, could overdose or slow down their breathing. And the federal government, because of these characteristics, has classified these medications differently. Methadone is what we call a class 2 medication, more risk. Buprenorphine is a class 3 medication, less risk. And then naltrexone, because it doesn't have any opioid effects, is not a class or a scheduled medication. So just for sake of argument, let's say there are 3 basic treatment strategies for opioid use disorder. One is treatment with an opioid agonist medication, such as methadone or buprenorphine, treatment with an opioid antagonist medication, such as naltrexone, and then sort of the other option, which is pharmacologic withdrawal or detoxification, followed by medication-free treatments. And I think part of the reason that it's important to talk about the role of medications in the treatment for opioid use disorder is that the success rate in folks being able to survive, avoid overdose, remain in treatment, and decrease their illicit drug use tends to be higher with the first 2 treatments compared to the bottom treatment. And I'll show some slides that sort of demonstrate that. The big rationale for the medications like methadone or buprenorphine is that they bind to the opioid receptors. And because they're sitting on that receptor, they prevent the person from feeling withdrawal and they take care of the craving. In addition, if somebody were to use fentanyl or heroin or OxyContin while they're taking one of these medications, these medications actually block the effect of other opioids. And so oftentimes my patients would tell me, yes, I tried something I used while I was taking the buprenorphine, but you know what? It was a waste of money. It was a waste of time. I didn't feel anything. And that's the property that not only are they getting their craving and their withdrawal addressed, but they're also getting this blockade effect. And there's a lot of strong scientific support. In fact, there's one paper that I'll just highlight here from the New England Journal of Medicine, probably about 3 years ago. And it's from the leaders of the NIH, Francis Collins, the former director of the NIH, and Nora Volkow, who's the director of the National Institute on Drug Abuse, and says these medications coupled with psychosocial support are the current standard of care for reducing illicit opioid use, relapse risk, and overdose while improving social function. However, limited access to providers and programs can create barriers to treatment. So clearly a lot of scientific support. And the next 2 slides will show you some of that scientific support. This is a large study published in the Journal of the American Medical Association that compared the probability of opioid overdose in patients receiving different types of treatments. And you can see here, the black line at the bottom is no treatment. So they had the lowest probability of not having an overdose. And the line up here is medication treatment with either buprenorphine or methadone. And so those individuals had the least likelihood of experiencing an overdose. And in between were the folks who got either detox or had a intensive outpatient type treatment. So strong evidence in large insurance claim database demonstrating that not providing treatment or sometimes just providing detoxification can increase the risk for overdose, because what happens is patients lose their physical tolerance and they go back into the environment and they use again and they overdose. This is another study. This is from Massachusetts, a large study that started with individuals who had non-fatal overdoses who came into the hospital. And they followed people for 12 months, and they looked to see what was the likelihood that they were going to die from an opioid-related mortality. And over that 12-month period of time, the triangles are methadone treatment. And so that was the lowest likelihood of opioid related mortality. That was just over 1%. The next line is buprenorphine, essentially a statistically similar outcome. And then the individuals in the higher line are individuals who received naltrexone, so probably around 3%. And one of the saddest things about this study is we learned that it's about a 5% per year mortality if somebody has a non-fatal overdose. And so if 100 people come into my emergency department, I know that 5 of them will no longer be here a year from now. And that's akin to cardiac disease and emphysema exacerbations and many other conditions that we see in acute care settings. That's a very, very high risk population. And that's one of the populations that we really need to make sure they get the best treatment. And this study demonstrated that we can decrease their mortality by 50% if they get onto a medication such as methadone or buprenorphine compared to those who didn't. This is a sort of a public health slide that looks at the association in the red line of heroin overdoses over time from 1995 to 2009 as the city of Baltimore increased access to methadone and buprenorphine. And you can see that there was sort of an inverse relationship. As there was more treatment available, the overdose rate went down in the city of Baltimore. So it's not just overdose and it's not just mortality benefit. There are lots of other benefits that we see in scientific studies when we look at the outcomes from patients who receive these medications. They remain in treatment longer. They have improved social functioning. They have decreased criminal activity, decreased drug use, decreased HIV transmission, decreased hepatitis C transmission. And in fact, the evidence supporting these medications is really sort of incontrovertible. And they've been endorsed by a number of entities such as the World Health Organization, the White House Office of National Drug Control, the President's Commission on Combating Drug Addiction and the Opioid Crisis, the National Academy of Medicine, the Surgeon General, the NIH, the Substance Abuse Mental Health Service Administration, the National Governors Association, and many, many others. Despite that, you'll see in this piece from NPR in 2016, the headline is "Treating Opioid Addiction with a Drug Raises Hope and Controversy," as if there's some controversy around using something that is so scientifically valid and supported. So I want to address this issue about just replacing one drug with another. I think it's important to realize that the medications, and I always refer to these as medications and not drugs, the medications that we use for treatment of addiction have been studied for at least back into the 40s and 50s. There was a lot of work that was done in Kentucky and Lexington in the 50s and 60s, especially as folks were coming back from Southeast Asia and Vietnam. And so they went through a lot of different medications and they found the medications that had almost the ideal profile. There were medications that you could take once a day, so they were long acting. So the route of administration of these medications compared to somebody who's, really active in their addiction, they're using them intravenously or intranasally. The onset of action of these medications is slow in onset rather than immediate in onset. And we know that the most reinforcing thing in addiction is if you have something that's immediate onset and highly reinforcing. And so we've chosen compounds and substances that have a slow onset of action. They also last for a long period of time, 24 to 36 hours. And one of the things I find that's very helpful in my patients is to encourage them to take their medication once a day. And that way they get out of this notion that every 5 to 6 hours, they have to look for something outside of their body to make them feel better or make them feel comfortable. One of the characteristics with opioid use disorder is, you're going to be in withdrawal and you're going to feel sick if you don't have access. And so there's a lot of time spent, using or recovering from use. And then the euphoria, the reinforcing aspect of these medications, if dosed appropriately, should really be absent. Whereas people who are continuing to use heroin, fentanyl, or prescription opioids, if they have an addiction, that part of what they're seeking is that euphoria. And I just have a quote up here. This was an unfortunate statement by an orthopod, Tom Price, who happened to be the director of Health and Human Services, luckily for only 231 days. But his statement was, if we're just substituting one opioid for another, we're not moving the dial much. And so I understand that these, unfortunately, most folks haven't appreciated the data that supports and the rationale for the use of these medications. So how long do we provide these medications for? Well, it's useful to look to other medical conditions. So, when do we usually evaluate outcomes in patients with diabetes or depression or hypertension? And, we usually, somebody's very symptomatic, we give them a medication, we see that their symptoms go down, we say, we stop the medication. And so we say, wow, that medication really works. And so we kind of focus on the during treatment period of time. That's not true for addiction or for opioid use disorder. We sort of say, okay, well, they were very symptomatic beforehand. We gave them their treatment. And gosh, we took away the treatment and now they're back doing the things they did before without focusing on how well they did while they were in treatment. So, it's important to recognize that there is very strong data to support longer durations of treatment with these types of medication. This is just one study, and then there are a number of them that have compared patients with opioid use disorder who got either detoxification or got ongoing treatment with a medication like buprenorphine. This is a fairly small study. There were only 40 individuals enrolled, 20 who underwent intensive cognitive behavioral therapy 3 times a week. They had their buprenorphine tapered over a 7-day period of time. They had their urines monitored. And you can see after the medication was taken away, after 60 days or so, none of those patients were still in treatment, as opposed to individuals who got the medication over a 12-month period of time. 16 of those patients were still in treatment at a year. And the sad thing to say, and 85% of their urines indicated that they were not using substances. And the really sad thing about this study is that 4 individuals in the detoxification arm passed away within 12 months compared to none in the arm, the treatment group that got treatment for a year. So these are the types of data that are in my mind when I'm talking to families and friends about what options there are for treatment. We all recognize that opioid use disorder is a biopsychosocial condition and should be addressed at multiple levels. I don't think anybody often argues for just medications by itself. But individuals who do take opioid agonist medication by itself can have benefit, either in morbidity, mortality. And we know that the addition of basic counseling to opioid agonist treatment is associated with increased efficacy, usually as measured by decreased illicit drug use and greater retention. That's been demonstrated in a large number of randomized clinical trials, 4,000 patients. And, the evidence indicates that adding psychosocial support does not really change the effectiveness of retention, as long as somebody's getting basic what we call medication management. That medication management, is something that targets the behavioral and psychological triggers that patients experience that lead them to continue to use, and helps them avoid people, places, and things, friends who use drugs, neighborhoods, bars, the comorbid medical conditions such as depression that can make use worse, encourages patients to make lifestyle changes, increased involvement in drug-free, pro-social, vocational, and family activities. A lot of my patients tell me that just being busy at work helps them keep their mind off of their addiction and their desire to use. And it also helps to address the social, legal, work, health, and psychological and family problems that result from their addiction. So I'll sort of skip forward. I'll just talk briefly about alcohol use disorder. Similar changes that we see in neurobiology with alcohol use disorder. The receptors are different. In fact, there's no single alcohol receptor. It's really sort of a group of areas of the brain that are impacted. They sort of dictate what we see with withdrawal and the negative affect or negative emotion associated with withdrawal, the preoccupation and the anticipation for alcohol, and then also the experience of binge and intoxication that we see with patients who are using alcohol. There are essentially three major medications that we use for the treatment of alcohol use disorder. They're listed in this slide. The first, again, is naltrexone. So interestingly enough, the opioid system is even involved in drinking behavior. That's a medication that can be provided either as an injectable, known as Vivitrol, or as a pill that patients take. And this is designed to decrease the craving and the reinforcing properties that patients experience when they drink, and has been associated with lower rates of relapse and less drinking when somebody is drinking. Acamprosate is another medication that we can use. This is important to start when patients, after they've had a period of abstinence, so usually about 7 to 10 days of abstinence. And then the third one that is probably underused and used in select circumstances is disulfiram or Antabuse. And this is the medication that impacts the metabolism of alcohol such that patients feel terrible, nauseous, wrenching, diaphoresis, sweating, anxiety if they consume alcohol while taking that medication. All of them are approved by the Food and Drug Administration, and probably naltrexone has the best safety and track record for benefit. This is a slide that just sort of shows the 30 or 20 or so studies that have looked at the efficacy. I'm highlighting with the red bars, everything to the left of the line that you can see there indicates better outcomes in people who take naltrexone. And when you sum up all of the data from all of these studies, you can see in the bottom that if you're to the left of the line, you're going to be less likely to drink. We use a metric called number needed to treat, which means that if we treat 20 people, We're going to lead to one who's not returned to any drinking, and 12 who haven't returned to heavy drinking. And this is not that different from the number needed to treat that we see when we use medications like that are SSRIs, like Celexa, Lexapro, Prozac for depression. So similar efficacy as we see for other types of medications. And then I'll end with a slide just to remind us all that probably the biggest killer addictive substance out there is nicotine. It's highly prevalent in the population and highly prevalent in patients with both psychiatric and addictive disorders, and that we do have effective medications, nicotine replacement therapy. I often encourage folks to use dual nicotine replacement therapy. So they'll have a patch and then they use the gum when they feel like they need it, or they use a lozenge. We also have medications like varenicline or Chantix, which can be highly effective, and bupropion or Wellbutrin or Zyban, which can be effective for medication, for tobacco use disorder. So stopping here, I'll just say that substance use and addiction result in changes in neurobiology. The medications that have been developed to address these changes, and those are combined with behavioral counseling strategies. And given the chronic and relapsing nature of addiction, oftentimes long-term treatment is more often effective than and life-saving compared to shorter treatment. Encourage you to look us up in the Yale Program in Addiction Medicine, either at our website or on Twitter. And with that, I will stop and be happy to answer any questions or engage in a discussion.
I've got a question. I actually wrote down several questions, so I don't know how many of these I want to get to, but a quick one, and you just finished up. What's the difference between tobacco use and tobacco use disorder? I mean, everybody has said for years that using tobacco at all is unhealthy and causes cancer. So how do you define a disorder versus use?
Yeah, so that's sort of the formal diagnosis for what might be called addiction. And so it indicates not only that physical dependence, so somebody feels like they need to smoke more to get the same effect. If they don't smoke, they feel sick, but also they continue to smoke even though, for instance, they may have emphysema or asthma or lung cancer, or they're spending $10 a pack. So that sort of loss of control is sort of the sine qua non for addiction and distinguishes it from just using tobacco.
Okay. Most of my questions surround the concept of harm reduction versus non-use. And I've read several articles about the efficacy of harm reduction programs. There were 2 articles, I think, in the Times or the Journal several months ago about programs in Toronto that had become quite effective. And the US doesn't seem to have as much of an emphasis on harm reduction. And we hear a lot more about people just trying not to use at all. So what's the long-term objective of these medication treatments? And is your program, would your program or medication treatment programs be kind of lumped into the harm reduction area versus the area where people are trying to just stop altogether? It's not a very well-founded question, but
no, I think I get your point. So I see what I do as treatment, and I see that as different from harm reduction. Having said that, I'm a primary care physician. I treat high blood pressure. I treat diabetes. Everything I do, quite frankly, is harm reduction. I don't think I've ever cured a single patient. And I'm being a little joking, a little facetious. It's where we live. And not all of my patients with high blood pressure have target blood pressure. Not all my patients with depression don't have depression symptoms. Same thing with diabetes. And so that's where things like harm reduction come into play. So I can counsel my patient, who has diabetes about appropriate diet, about exercise. And so I see that akin to the same way when I'm treating somebody who has an opioid use disorder. They may go from using 5 times a day to 5 times a month or 5 times a year, or never. But if they're going to use, I want to make sure that they're going to use in a way that's safe, clean needles, fentanyl testing, all of those things that I know will decrease the impact of the disease on their functioning. I'm not, my goal is for folks to get control of their condition and to improve their social functioning, and so that to get their disease into a remission, as I do for other conditions. Now, having said all of that, from a public health standpoint, from a sort of a societal and moral standpoint, I think there are a lot of things that we could make more readily available that would decrease the body count of deaths that we're seeing on a regular basis. 1,200 deaths a year in Connecticut is just untenable. And whatever we can do to address that, and then getting people to a place where they can start to talk about treatment and they're ready for treatment, I think is really key and important for us. So that's where a lot of harm reduction tools come in.
Thank you. Thank you.
Yes. Yeah.
I have a question. So we have an addicted loved one who was subject to the had real pain issues like 15 years ago, was prescribed, kept bumping it up for tolerance over 12 years, and lost his job at one point, and then turned to heroin for a short period of time. We got him back home. He's been sober now from heroin for over 2 years and is on bupe. It's been very good, the buprenorphine. But my question is there a treatment plan that, that allows, is he on bupe for the rest of his life? How does that treatment plan work, over time? I mean, does he ever get back to, they wean you or they don't? Unfortunately, his psychiatrist just passed away, and we're trying to, reconnect, and he is not re-engaged socially completely yet with a job and things like that. So those are other issues, but I was really focused more on the treatment plan on bupe, as far as, because I understand what it's doing for him, but does it, do you ever get those receptors, do you ever get back to normal or not?
Yeah, those are a lot of great questions there. And each case is different. Each individual is different. Again, to use maybe a depression analogy, where somebody, oftentimes, again, I'm not a psychiatrist, but psychiatrists will, try 6 months of a SSRI and then sort of taper it down and see if the person is doing okay without that type of medication. 6 months is a short period of time for an addictive disorder. And so we typically like to see longer periods of stability. And oftentimes my goal is, I want to keep my patients alive and I want to keep them functioning and doing well. And if they're not if the benefits are outweighing the risks, and there are very few risks with these types of medications, then, it depends a lot on how much distance they get from the people and places and things that were creating problems for them. If it's a mid 30-year-old person and they're about to have their first child or their second child, that's probably not the right time to think about tapering down on the medication. But I often, in my practice, after a period of stability, I will work with a patient if that's what they're interested in doing, taper them down. And so sometimes I do have patients on very low doses. I may stop for a period of time. They start to feel like they're going to relapse and they come back, and I always leave the door open. But, with the current environment and what's out there these days, I think, it's not unlike my patients. I can tell you all my patients with diabetes and high blood pressure, they want to be off of all of those medications too. So, if the risks are greater than the benefits, or the benefits are greater than the risks,
The last question, that's a good analogy to use, like diabetic, or so I can think of it in those terms. Like it's not hurting him. It's not creating any additional issues. It's maintaining, it's like a diabetic. The receptors were blown and now we're medicating them.
Yeah, the biggest thing is constipation, quite frankly. That's the primary side effect.
I was told not to eat his Dee Dee, his granola the other night. Now she's right again. Thank you.
Ms. Pohl, Ms. Pohl? Yeah, hi.
Yes, Liza. Thank you so much for your presentation and for spending time with us after, I'm sure, a very, very busy day for you. So we appreciate it. I'm not even sure if I will phrase this question correctly, but I'm going to give it a go. Does the neurobiology and the changes in the brain return to normal after a certain period of time of abstinence, treatment, whether it's medication, therapy? I'm personally specifically more interested in alcohol and marijuana, but did I say that right?
Yeah, no, that's very helpful. And I realized that was actually part of the prior person's question. So
Yes.
the answer is yes. It's just this fascinating aspect of the brain, which is termed neuroplasticity. And Nora Volkow, who's the head of NIDA at the NIH, tells a story about the cab drivers in London and how there's certain parts of their brain are twice the size of other individuals. And it's because the streets are so complicated and they've remembered these maps. And it just, it shows you the potential that there is in the human brain to change over time. And there are studies that have been done that they sort of look at people who have been on methadone, for instance, for a short period of time compared to a longer period of time, and then compared to a group of individuals without opioid use disorder. And the scans of people who've been on the medications for a longer period of time are quote unquote more normal, or more like those individuals who don't have opioid use disorder. We're actually, this is really the next frontier. And I think it's probably not only true for medications, but also for some of the effective counseling therapies that we use, cognitive behavioral therapy, where you just sort of develop these different pathways and different ways to think about things that result in observable changes in the brain.
May I just ask as a follow-up, how can we know when that's happened for our loved ones?
Yeah, no, and I think, I think while the gadgetry and the imaging and all of that's a lot of fun, I think you kind of know, what I would call clinically, or just the way you know your family member. Are they-
Behaviorally.
Yeah, exactly. It's what you see and what you observe, and recognize that it's not, it's not there's no quick fix, right? In this area, and things can take months to years and to develop and become bad, and they can also take months to years to sort of revert, and it's not always a linear process.
Thank you so much.
Of course, my pleasure.
David, I had a question just if there's some kind of rule of thumb that methadone would be the most difficult to titrate off, and if you were going to even try, it would be, 5 to 10 years, and that, Suboxone might be something that could be, theoretically done in 2 to 3 years, and then naltrexone would be different, but you pointed out the different success rates and everything, but would that be kind of a good rule of thumb that it's more difficult for methadone than any other?
Yeah, it's I think as a blanket statement, that's probably safe assumption. That so part of that graph that I showed you just demonstrates the power of these medications at the opioid receptor. And so obviously a medication that has more strength or power typically leads to more physical dependence and can take a longer period of time to quote unquote wean down, if that's what somebody chooses to do. And it's not unusual for us to think about switching from one medication to another. If the goal is to wean down, you might, for instance, move somebody from a methadone to a buprenorphine. And then over time, I often offer, if somebody wants to come completely off of buprenorphine, I offer them the option to take naltrexone, because at least I know there's something in there for a protection standpoint. Now, the caveat there is we've used that medication for a shorter period of time in fewer patients, and we don't have the same data to demonstrate its ability to prevent overdose or overdose death. And so it's plausible, but it's not as proven as we know for the other medications.
Okay, thanks. And just one other thing was just in terms of, cocktails, and this is where probably you get into psychiatrists, and you mentioned SSRIs as well as naltrexone, but maybe the results are different if naltrexone is used with a antidepressant. In fact, I was talking to one person that had been struggling for many years with an alcohol use disorder, and he said, "Yeah, it was 2 years. Naltrexone, Wellbutrin, and gabapentin were the 3 ones together. But after 2 years, I was able to get off all 3. So there's kind of a little bit of an art to this of working with multiple medications at once."
Yeah, I mean, that's I think it's important and to recognize that those are oftentimes distinct conditions that exist in the person simultaneously. So some people have alcohol use disorder and it results in them feeling depressed, and you take the alcohol out of the picture and their depression improves. If the depression doesn't improve, then it's useful and worthwhile to treat both. And so you might not only be on the naltrexone, but you're also on the Wellbutrin to address their what we would call a comorbid psychiatric condition. And I think that's one of the challenges, quite frankly, that I find in my internal medicine colleagues, is that they oftentimes aren't able to separate out the psychiatric condition from the addiction condition and realizing that, well, this person is kind of hard to work with, not because of their addiction, it's because they have maybe a personality disorder or they have untreated depression or something else that's going on. And so it's really, we get into this area of sort of parsing out different conditions and making sure we're treating each appropriately.
Thank you.
Yeah. Hi, Dee Dee.
Thank you to you for being here with us, and thank you, Paul, for your continued contact with us and support through all of this. I'm very grateful to have our loved one home. I'm also looking forward to him being a 37-year-old man, independent and perhaps happy and living in his own place. That's the goal. However, it's been a really rough road. After having been diagnosed with palindromic rheumatism, he has intense pain, but it's erratic. That's why the doctor who unfortunately passed away at the end of December was, he thought that the bupe medicine was going to be the best way for him to go, because he would still get a little bit of pain relief, but not where he was at the chronic pain clinics for 10 years, which took him down a really dark path. And so in this journey to get out of our home and get into his own home somewhere, he seems to be having difficulty he is a Lyft driver, but he's having difficulty re-entering his life. I'm very happy that he's clean, and that there is this MAT program. Is there a stigma that's attached to being on the MAT program, which might be holding up the application process that he's been in? Is it just the job market in general? I'm not sure. Or is it just fear? Or yes, I think there are other issues. And I was really pleased one night when he said, "Mom, I think there's a possibility that I may have had some problems before this whole addiction process road appeared," which is wonderful. He does have a therapist that he sees every other week, but and I do realize this is a very long road, but I am wondering about, somebody needs a job in order to pay rent somewhere. So are your clients finding it difficult? Is this do employers say, "Oh, we don't want to be involved with somebody who's in a MAP program because they're a risk," or are they even told? I don't know. That's it for me. I think there was a question in there somewhere.
Yeah, there are a lot of important issues that were brought up. I think one is this overlap of, there's almost this Venn diagram of people who have opioid use disorder, or people who have chronic pain, and then individuals who end up having both. And we as a profession haven't done a great job in developing treatment delivery systems that can address both very, very effectively. My understanding is that cognitive behavioral therapy, if you're able to identify it and find somebody who can provide it, has been shown to be most effective for both chronic pain and opioid use disorder, and probably for the combination, as well as for sleep, in case that's an issue. It's a very common issue for individuals. So potentially finding a good cognitive behavioral therapist for somebody who has these types of conditions can be very useful. The issue of stigma is just so profound. It's, I had the opportunity to work with Ingrid and others to develop a strategic plan for the state of Connecticut 6 years ago to address opioid use and addiction. And it was one of the 6 most important things that we listed, was to address the issue of stigma, especially stigma against the most effective treatments. You know, I always say that this field needs its Magic Johnson. You know, we need somebody who's a well-celebrated celebrity who can say, I'm on buprenorphine, I'm on methadone, I've been doing great. We only really hear about folks who, you know, who've done it through different pathways, and I'm totally cognizant of the value of multiple pathways, but you know, given the mortality benefit that we see, that we really need to a process whereby we can change the way folks feel about living next to somebody or having them in their family if they're taking an effective medication that gets their condition under control. Staying busy, getting into meetings, meeting people who they can be with. You know, that's one of the values of, you know, I often send my patients to AA, even if they have opioid use disorder, because they say they hear great stories of recovery. They get engaged with people who are not using. And pretty much every AA meeting I've been to, there's always at least a few people who talk about the drugs that they've used in their past. And so I don't think you can really find these pure rooms anymore. But you know, that having that social environment that you can be in and getting back to work. Yes, now this is a tough economy, and you know, I worry for the folks who are the most vulnerable these days.
I have just one other question quickly. Is there a list somewhere in Connecticut? I know that he's 37. He needs to figure this out for himself, but just for my own personal information, which I have a sponsor who said that's okay to do, I'm just wondering if there is a list of MAT doctors that's posted, published, whatever, somewhere, because
Yeah, no,
that's
actually,
great.
yeah, so there's if you go to the SAMHSA website, and I'll share this information with Paul after the call, there's a list of buprenorphine providers. I would use that as opposed to the list that Beacon Health Options puts out there in the state, because Beacon Health Options only includes people who are in the mental health area, and so you don't get somebody like me, because I'm just a simple primary care doc. That's how siloed our crazy system is. You know, because I'm a medical person and not a mental health person, they don't even list me on the website. It's absolutely, it's a disservice to the public, quite frankly. That they don't-
Definitely. Are you taking new patients?
I'm not, but my colleagues are. Yeah.
Thank you.
Liza, you have one last question?
Yes, well, more just a comment. I loved that idea of yours about a Magic Johnson, you know, person to help in this area. Not sure he's as famous as Magic Johnson, but Matthew Perry just came out with his book, and I saw the interview I think he had with, was it Diane Sawyer? And
Right.
I don't know. I'm not sure if he's on medication now, but he would be a great, I hope this isn't demeaning, but poster child, you know, kind of, yeah, I thought that was a great idea.
I think it does help for folks to see people that they can relate to at some level, to realize just how prevalent this is. And, you know, it's not uncommon when people hear what I'm doing. If I go to a party or something, it's like, oh, well, did you know my friend, my cousin, it's like, yes, no, it's in every family. I'm not surprised.
Yeah. Wow. This was great. And, you know, what my impression is compared to other states, the addiction medicine program at Yale is very unique. And it's awesome that you've been the head of it. So when did that, you've been in your role as director for how many years? 8? Or is it close to 8 years now?
Yeah, we sort of formally started it in 2017. Addiction
Oh, okay.
medicine became its own board certified through the American Board of Medical Specialties in 2015. So that's 7 or 8 years now. And,
That's
you know,
great.
the beauty is we've got emergency medicine physicians who are boarded in addiction medicine. We've got pediatricians. We've got liver doctors who take care of patients with alcohol use disorder. We've got infectious disease physicians. And we, like I said, we work with our colleagues in public health and nursing and try to, you know, to make sure that all the health professions are addressing these issues.
And you have is it a weekly or bi-weekly or monthly email that goes out about events or programs from Yale? Is that correct?
Yeah, so we have a weekly email that goes out. And it's both things that are happening here and things that, quite frankly, I see that are happening elsewhere. And everything's remote these days. So it kind of helps people take advantage of opportunities around the country and around the world. And then twice a week, we have what are called our addiction medicine rounds, which is usually a faculty member from here or from another institution talking about the work that they're doing, either research or educational.
Wow. Well, that's a great resource. And I know people can get to it through going, you know, to the program of addiction medicine at Yale, correct?
That's correct.
All right. Well, great. This has been awesome. And I was hoping that some other people besides me could thank Dr. Fiellin for being here today. And thank you, Doctor.
Thank you.
Thank you. Thank you very much.
Thank you for the opportunity. I really appreciate it.